Thank you. And I'll again thanks the organizing committee to give me this opportunity to share our experience in intervention radiology for pediatric hepatic tumors. So I will describe some of the procedures that we do for hepatic tumors and for hepatobiliary system as such. So for the liver, we do vascular and non-vascular procedures. In the non-vascular, it is essentially the biopsies, the various drainages, biliary interventions, and ablative therapies. And the vascular, it is more of embolizations, chemoembolizations, portal vein embolization, and sometimes the diagnostic venography. So one of the important interventions that we do is biopsy. Most of it is done ultrasound guided, but sometimes it is done CT guided when we need to target the non-necrotic part or enhancing part, and it is if it is critically located. We essentially use the coaxial systems where we use an outer needle through which the true cut needle is introduced and multiple sections or specimens are taken. And sometimes these tumors are vascular. So there is a possibility that these tumors post biopsy, they may bleed. For example, in this patient, there was active extravasation after the biopsy. And on CT scan, you can see that there is contrast pooling and patient was bleeding inside, which so there should be a provision to embolize such lesions whenever we are taking them for biopsy. So this particular patient was taken immediately for angiography and the bleeding artery was embolized. I mean, there should be provision to do the biopsy as well as we should be able to tackle the complications as well. Another important, simple but important procedure is the percutaneous transhepatic biliary drainages. The patients sometimes they present with obstructive jaundice. So to optimize them for surgery or further therapy, and sometimes post-operative complications, the biliary drainages are required. For example, this child who had been operated for hepatoblastoma with extended left hepatectomy, and after 6 months post-operative, he developed fever spikes and biliary obstruction. So you can see that there is a bilioma which has accumulated bile here with bile leak, and at some points the biliary system was dilated as well. So we need to drain the bilioma, and also we need to divert the biliary system and get access to the bowel so that an effective drainage is achieved and patient comes out of sepsis and further definitive surgery is taken. Another patient of neuroblastoma with obstructive jaundice, again, biliary drainage system procedure helps him to relieve of the obstructive jaundice. Once the bilirubin is within range, the further treatment can be started. Sometimes post-operative complications like the biliary leaks are encountered, which again need diversion by biliary drainage. This is the biliary drainage which is showing a leak across the anastomosis. In such cases, the covered stent comes to help. We cover the leak with covered metallic stents, and which helps to heal the injury, and the patient recovers over a period of time. Some rare cases like endobiliary rhabdomyosarcomas are encountered where even after chemotherapy, there is a significant intrahepatic biliary dilatation with increasing bilirubin. The plan for this patient was to do biliary diversion and with endobiliary access for radiotherapy, stenting, and then further treatment. So now you can see that the intrabiliary lesion causing biliary dilatation, this has been drained with percutaneous biliary drainage, and brachytherapy, intrabiliary brachytherapy is offered to the patient. Coming to various ablative therapies, which has become one of the modalities for treatment of patients for various tumors with a minimally invasive way. The most established one is the radiofrequency ablation, where the electrode is placed under image guidance into the tumor and a high frequency electric current is passed so that thermal energy is created, and we try to achieve the coagulative necrosis of the tumor. So these are the kind of generators and electrodes that we use for radiofrequency ablation. This is an example of a patient with hepatoblastoma who had undergone chemotherapy followed by hepatectomy, but during surgery there were lesions intraoperatively detected. So those lesions were targeted, and so this was the primary lesion which was operated, and there were other lesions which were detected in intraoperatively. Those were targeted with chemoembolization followed by radiofrequency ablation. So we do chemoembolization in such cases just to locate the tumor, which makes technically easy for us to target it under CT scan for radiofrequency ablation. Another simple treatment procedure that we do is a vascular embolization for patients who land up with tumor rupture. For example, this girl who had bilateral lung mets, hepatoblastoma with bilateral lung mets, in essentially a palliative setting, but she presented with tumor rupture and hemoperitoneum. This was the big hepatoblastoma, and there was a hematoma. So an angiography was done, and embolization of the tumor vascularity was achieved, and the hemostasis was obtained. So this is a follow-up where we had significant necrosis and shrinkage of the tumor, but it was essentially a palliative procedure as a to salvage the life-threatening hemoperitoneum. We have for such embolizations, we have done for spontaneous bleeds, iatrogenic bleeds, some hemodynamic instability. Patients sometimes present with severe abdominal pain, but in all these cases, we could stop the bleeding with endovascular approach. Sometimes we do transarterial chemoembolization as in a neoadjuvant setting, where essentially we access the vascularity of the tumor with superselective cannulation and infuse the chemotherapy so as to downstage the tumor as a bridge to surgery, or sometimes in palliative setting. So essentially the chemotherapeutic agent is injected into the tumor bed itself. So the side effects of the chemotherapeutic agent are less, and we can give high dose into the targeted tumor bed itself. So this is an example of a hepatoblastoma, a 1-year female child who was given chemotherapy followed by transarterial chemoembolization. So this is the tumor vascularity which is accessed through superselective cannulation, and the chemotherapeutic agent, essentially the doxorubicin and cisplatin along with lipiodol, is injected. Over a period of time, there is significant shrinkage of the tumor with decreased AFP levels. We usually follow these patients with basic parameters after 2 weeks, and the imaging is repeated after 6 weeks to assess the response to the treatment and whether to repeat the chemoembolization or to subject the patient to surgery. The advantages of chemoembolization are it can be used as a procedure as a bridge to transplant, as a bridge to surgery, and it helps us to reduce the tumor volume. It decreases the alpha fetoprotein and reduces intraoperative hemorrhage. So as an adjunct to the definitive surgery, this particular treatment can be used in neoadjuvant setting. There is good evidence in the literature now that the preoperative chemoembolization helps to improve the outcome of the hepatoblastoma. Coming to chemoembolization as a bridge to surgery, this was the patient, a 1-year male child with hepatoblastoma, who has received chemotherapy, and the FLR was adequate. So in this patient, we did the chemoembolization by cannulating the vascularity of the tumor, and this is the chemotherapeutic agent along with lipiodol. This is how we get the distribution of chemotherapeutic agent mixed with lipiodol so as to downstage the tumor further for definitive surgery. Sometimes the embryonal sarcomas, they are also known to respond to transarterial chemoembolizations. And in this particular case, we used drug-eluting beads with chemoembolization, which act as a sustained release kind of delivery of the chemotherapeutic agent over a period of time. So this was the patient who had a vascular tumor, an embryonal sarcoma, which after chemoembolization had a significant necrosis, and there was no active tumor. So out of the various hepatoblastomas, embryonal sarcomas that we had done chemoembolization for, the overall results were encouraging. Coming to portal vein embolization, as was highlighted by the previous speaker, whenever we encounter that the future liver remnant may not be adequate for the definitive hepatic resection, in such cases, the portal vein on that particular side is embolized so that the opposite side or the rest of the liver gets hypertrophied, and we get adequate future liver remnant so that the patient can sustain a major hepatic resection. So usually the FLR is calculated by subtracting the volume of the tumor from the volume of the liver. And by as a thumb rule for residual in healthy liver, it should be more than 20%. And when after post chemotherapy, we should have at least more than 30% of FLR. If not, then a procedure called as portal vein embolization can be useful. So here we use a software called as Miriam for auto segmentation of the various hepatic vessels and biliary radicals. And this is how the auto segmentation is done for the arterial, venous, and biliary system. And we assess the kind of healthy liver, the tumor, and the potential plane of resection with the future liver remnant. So there, for example, in this patient where we were planning to have subject the patient to surgery, but there was inadequate FLR, this patient was subject to portal vein embolization. The portal vein embolization is done by percutaneously puncturing the portal vein. If the portal vein is accessed, and we use either polyvinyl alcohol particles or glue to embolize the vascularity of the side of the liver which needs to be resected. So you can see that before surgery, the FLR was quite less or inadequate, while after the portal vein embolization, there was significant increase in the FLR, and patient could sustain the hepatic surgery with adequate FLR. So this is a simple but quite useful procedure. One simple procedure that I would like to highlight is the assessment of like the hepatic IVC-gram or venogram, which may help to assess the vascular invasiveness of the tumor, so that the surgeon can take a judicial decision regarding the surgery, or whether to downstage the patient and then take up for surgery. So these are the various kind of procedures that can be offered by an interventional radiologist for the hepatic tumors, which are essentially as an adjunct to the definitive surgery. Thank you.